This is caring for children in diverse settings. So why do kids come to the hospital? Well, under 5, the most common reason is respiratory diseases. Older than that, we've still got respiratory diseases, but also mental health problems, injuries, GI disorders. Adolescents, the most common reason they come in is pregnancy and childbearing, followed by mental health and injuries. So how do kids react to the hospital? Well, with anxiety and fear. For many of them are afraid of bodily injury, and they're afraid of pain. We do a lot of procedures that are painful. The separation anxiety from middle of infancy through the toddler stage, this is the biggest problem for them, is being separated from their parents. And loss of control. They can react with anger, guilt, or regression, which means things that they had already stopped doing, they go back to doing, like sucking their thumb or needing a diaper or wanting a bottle. And that's normal. Reassure the parents it's just a reaction to the hospitalization. So what are some things that affect that reaction? Well, their developmental level. Infants are in the process of developing trust by having their basic needs met. So if they can't have those basic needs met, for example, their NPO, we still need to find ways to help them develop trust even though we can't feed them. Toddlers want control, right? Me do. They want to explore everything around them, and they love routines. They don't like things to be unpredictable. They like predictability, which we call ritualism. We can keep their routines. Every morning you get up, you brush your teeth, you put on clothes, and you eat breakfast. We can do that at the hospital. Most of our kids wear their own clothes, so find out what their routines are and follow them. We can let them explore in a limited scope. We can let them have control in a very, very limited scope. There's a lot of things they don't have control on, but they can pick what they're going to wear today. They can pick what TV show we're going to put on, things like that. And this is also the age of tantrums. Tantrums, we want to make sure the child is safe, but try and ignore the tantrum as much as possible. Preschoolers are very afraid of mutilation or loss of body integrity. Things like surgery, they're afraid you cut them open and all their guts are going to spill out. Or even a shot. How do you stop your insides from leaking out? So that's part of why they love Band-Aids. It reassures them that it's okay. But showing them, doing it on a doll, showing them what it's going to look like, that's going to help with that. Preschoolers have magical thinking, and I think that's one of the funnest parts of working with preschoolers. They don't have a good differentiation between real and pretend, but it also means that they don't have that in dealing with hospitalization either. One of the things that falls into magical thinking is that they think thoughts can cause actions. So a sibling who didn't like the baby because the baby came home and cried all the time and wanted the baby to go away, and then the baby goes to the hospital. Now we have a preschooler who's feeling guilty thinking the baby's in the hospital because that's what they wanted. So even though that can be a fun thing, we need to make sure that we're considering that, and it can also add to the child's stress. So school-age kids, these kids are busy all the time. Don't let them come to the hospital and just be bored. Let's get activities for them, things they like. Let's bring in crafts or board games or books, schoolwork, the things they're used to doing. Let's keep them doing. Adolescents, they're worried about body image, and they're worried about staying connected with their friends. So let's give them honest information of what's going to happen to their bodies and find ways to keep them connected with their friends. iPads, iPhones. At Valley Children's, we have teen time down in the classroom in the afternoons. So separation anxiety. This is for our older infants and our toddlers. Anybody who's had a child knows this. You try and leave your child and you just can't even get them off you, right? They're in that protest, crying, screaming, hanging on. After that, they go into despair, where they kind of get withdrawn. They're no longer crying and screaming, but they're just not interested in anything around them. They don't want to play. You can't really interest them in anything. The third stage of separation anxiety we rarely see, which is good, because this is really kind of leads to long-term emotional problems. This is where the child gets through the despair and they look like they're doing better. They start having interest in things. They start interacting with people, but everything's at a very superficial level. They don't really make deep and lasting connections. So here's our protest phase, and here's our despair phase. So how about parents and siblings? Well, some parents find it really hard to watch their child in pain. Don't make them come in and watch painful procedures. Other parents really want to be there, so leave that up to the parents of what works for them. Parents have a way of feeling guilty. I should have been able to prevent this, and sometimes there was nothing they could have done to prevent it, or even if they did make a mistake. We can't change the past, but we can ensure the child gets the best care possible now. And moving forward. Many show denial, anger, depression, confusion. How can this be? Or this can't be. My child can't have cancer. Just keep repeating things. When you hear the word cancer, you hear nothing else that's said after that. So often things have to be repeated multiple times. Just takes a while to break through that denial or that anger. Siblings can be very jealous. All of a sudden, the sibling is getting tons of attention, and they kind of feel forgotten. They might feel insecure. Can this happen to me? Or they resent the fact that that sibling is getting so much attention. Confusion. They don't know what's going on. We need to make sure we're keeping them in the loop. Anxiety. They don't know what's going to happen. Is my sibling going to die? So, don't ignore the parents and the siblings. So for the hospitalization, we want to do good preparation as much as we can, and the child needs to see it. So using dolls or stuffed animals, our Child Life at Valley Children's has dolls with everything we can possibly do to a child. So get them involved to show the child what they're going to have done, what it's going to look like afterwards. Be careful what terms you're using. Some medical terms kids don't understand. Others just sound scary. So you think about the child's age and what they will understand and use appropriate terms. Let kids touch equipment. It's not so scary when they touch it and realize it doesn't have whatever they're afraid of on it. Tell them what's going to happen. First, we're going to wash your hand. Then we're going to put on like a tight rubber band and look, and then the poke will come. So they're afraid from the beginning, so reassure them the parts that are not the painful part. Let them see the room. This is where you're going to have surgery. This is where you're going to be after the surgery. This is where the TV control is. The more they can be familiar, the better. Introduce them to the staff. This is the person who'll be here tomorrow when you come in for surgery. Explain what they're going to, not just what they're going to see, but what they're going to hear. Are there any, sounds, smells, other things that are going to be going on? So, types of admission. General admission, a child is admitted to the hospital. Sometimes we know in advance and can prepare them, but not always. In an emergency, we can't, right? They may go straight to surgery, and we're having to do that preparing after the fact, kind of a debrief instead of pre-brief. So making sure they understand what happened, that this is not their fault, that whatever is going through their mind, that we help them through that. ICUs, when kids go to the ICU, it is really scary for the family. But they also kind of get used to the ICU and having a one-on-one nurse, and then we send them down to the floor, and all of a sudden they feel like nobody's watching my child. This nurse has 4 patients instead of 1, instead of, being right outside my doorway. So we kind of have to wean parents off the ICU and remind them this is good news. Your child doesn't need as close of watching because they're doing well. Isolation. Studies show that we ignore kids who are in isolation, and I get it. It takes time to put on that gown and mask and gloves, and you leave and the kid needs something and now you got to put it all on again. Yes, don't ignore kids just because they're in isolation. It's hard. It's easy to do, but don't fight against that. Outpatient. This is wonderful that the kid doesn't have to stay in the hospital. They get to go home. They get to be with their family. But it also means we have way less time to do teaching. We need to make sure they know what to do at home, and you have a very short time to teach that, and they may say yes, they understand, then get home and they don't really remember. So make sure they have someone in some way to call to clarify questions that come up after. Kids who go to rehab, the family is very involved in rehab. That's part of what rehab is training the families to do the care for the child. So how do we promote coping in children? Well, you can do the same things we do. Take deep breaths, count to 10, use distraction techniques, know what works for that kid. Does their favorite TV show, does their reading their favorite story, what will work to help them distract from pain? Playing with their favorite toys, imagery, imagining their favorite place, therapeutic play. So this isn't just give them toys and let them play, but let them have dolls to act out what they're going through. Let them draw pictures of what they're experiencing, kind of a way of coping or processing what they're experiencing. Music. For some of us, music is a great coping mechanism, and children as well. Make sure we give that age-appropriate education before something happens as much as we can. We want them prepared before. And then don't forget the siblings and the family. We need them prepared as well. When siblings are home, frightened, not knowing what's going on, they're going to act out, which is going to make the parents more stressed, which is going to make the hospitalized child more stressed. So we're going to help everybody cope with what's going on. So here's some activities, reading books. We do want to make sure children are safe, and this is not the kind of hood that we have at Children's, but if you have a toddler, you got to make sure that they can't get out of the crib. And I really like this picture. If you cannot reach what you need while holding on to a baby, you got to pull the side rail up to go get it. You can't just take one step away and be right back. If I were her, I would actually have my hand around the child's arm or leg, not just, gently on the tummy like that. But if you can't reach it, you can't pull up the rail. You can't go get it. Restraints. We don't use restraints unless we need to, just like with adults. So you have to document why you need the restraint and what else you've tried. You need to try at least one thing. Maybe I tried talking to them and tried to distract them and it didn't work. They were still pulling on their tube, and so we put restraints on. You're supposed to use the least restrictive restraint. Policy generally is you've got to take it off at least every 2 hours and assess the skin underneath, and you need a written, you can go ahead and put on the restraint if you need to, but you need a written order and the provider to come and see the child face to face and agree that you need that within 1 hour. So here's some restraints that we have. The soft wrist restraints. This kid can still move a little bit, but not quite enough to pull out whatever tube they're after. Elbow restraints. So she can still move everything, but can't rub where she just had surgery for a cleft lip. If you have a child with an IV, they're likely to have an arm board, either on their hand or their foot. That is not a restraint. So that does not have the same policy. That is a securement device. There is a policy, but it's nowhere near as strict. It's just we have to be assessing the site.